would like to ask a question pertinent on the topic, please press the icon at the bottom of your screen that says chat. That'll bring up a box onto your screen that allows you to type in your question and then press enter to send it to me, and I'll be sure and pass the question along to our panelists. Telemedicine has probably been around for a little over a decade in some form, but very few of us physicians were ever users of it, in part because of some of the obstacles that were in place at that time, and also the hesitancy for insurers to reimburse telemedicine in an adequate manner. But then our government got involved, the Florida legislature last year, in an effort to try to make healthcare more affordable and accessible to Floridians, passed a bill on telemedicine. And in that bill, some things were passed that necessarily weren't in our favor, in that out-of-state practitioners and physicians had a mechanism that they could practice telemedicine in this state. They also expanded the definition of telemedicine to telehealth, so that people in occupations other than allopathic and osteopathic physicians could also provide health care in the form of pharmacists, therapists, etc., through the telehealth mechanism. Still, it hadn't really kicked off until the COVID-19 pandemic came on. And then telehealth and telemedicine has soared, partly, and it became one of the main avenues that we could have some revenue as physicians, but also it became a must if we were to take care and have contact with some of our elderly and vulnerable patients. As the pandemic has gone on, the government has loosened some of those restrictions, and also now insurance companies are reimbursing us for the care. And a lot of the barriers that heretofore were part of telemedicine have gone away. The government in the Department of CMS, who makes the guidelines for Medicare, are going to be publishing some payment schedules in the upcoming days and weeks on telehealth, and hopefully some of these restrictions that have been temporarily gone away during the pandemic, some of those restrictions will still be gone, and also payment will still be there for the process. They did a survey of patients who had done telehealth, and they found that those initially that were signing up out of necessity would like to continue telemedicine, but now want it out of convenience. So we as physicians need to be ready. And with that as our platform, I would like to introduce the two speakers that are going to help us with some vital information. Joining us here in Tampa is Jessica West, and Jessica is a senior associate at a law firm of Shumaker, Loop, and Kendrick here in Tampa. And as a member of Shumaker's healthcare team, she advises a wide range of healthcare providers on regulatory and compliance matters, fraud and abuse, licensure, certification, and emerging areas of health law, including that of telehealth. Welcome, Jessica.
Hi, thank you.
We also have joining us Patrick O'Doherty. Patrick is Vice President of the ProAssurance Companies, a medical malpractice insurance company that has been a long-term benefit provider for us here at Hillsborough County Medical Association. And Patrick has over 30 years of experience in the insurance industry, focused mainly on professional medical liability insurance. Welcome, Patrick.
Thank you, sir.
With those introductions, I'm going to allow you, I know Ms. West, you're going to be leading the way and going first, but if you guys want to play off of each other's knowledge and information during the session, at least now we know who you are. And Jessica, I'm going to turn it over to you at this time.
Okay, thank you, Dr. Cromer. Let me go ahead and share my screen with everyone so that you can see my slides. Yes, so as Dr. Cromer said, I'm an attorney at Shumaker, Loop, and Kendrick. I'm in our healthcare law department. We have about, I think right now, 11 healthcare attorneys that are doing 100% healthcare law all the time in our office, but we're a full service business law firm. We do have this nice client resource center that's specific to COVID-19. A lot of you, in addition to being physicians, are also business owners. So not only are you dealing with the pandemic on the health front, but also from the perspective of running a business, and we address a lot of those issues there, from employment law, to healthcare issues. And then we also have this legal and legislative helpline that people can call 24 hours a day, and somebody should be able to answer and help triage any questions. That was really something that we put together when new laws were coming out almost daily, and people, from one day to the next weren't really sure what they were going to have to do. It's died down a little bit, but as we see things surging again, who knows what's going to happen. It might be a similar situation, knock on wood, not, but that's there in case you need it. So I'm going to talk about telehealth before, during, and after this COVID-19 pandemic. So before everything really started heating up in January, we'd already seen a big increase in the desire, both on the patient side and the provider side, to have greater accessibility and payment for telehealth. All 50 states, it's kind of a patchwork situation with the telehealth laws as far as state law and regulations go. There's a lot of variability between the states. As Dr. Cromer mentioned, Florida just came out with the new statute last year that was replaced. Previously, we only had regulations from the Board of Osteopathic Medicine and the Board of Medicine for medical doctors, setting forth, the different requirements for them, but that was replaced with this new law that's broader. It clarifies some things, but again, it kind of opens things up more additionally to out-of-state providers and to other providers in our state. So some states require out-of-state providers to be licensed in their state in order to provide telemedicine services to individuals located in those other states. And some just require you to register as an out-of-state telemedicine provider rather than go for the full out-of-state license in the state. It was kind of a patchwork, and it still is. And that's something that I'm going to talk about as a consideration that you never want to forget, even when federal law has made some exceptions. So 42 states had some sort of healthcare or telehealth commercial payer law, although most actually don't require coverage or payment parity. So in the Florida law, the healthcare plans are not required to cover services that are delivered via telehealth.
Hey, Jessica, can I jump in just for a second here?
Sure.
Okay, so, what we've seen in our world is, because we are a national carrier, you really have 50 sets of state laws that talk about the practice of medicine within that state. If you look at some of the telehealth laws that are out there, most states have 2 sets of laws. They have a law of what they say other people that are outside of their state can do to practice within their state, as you pointed out. And then they have a law set that says, what can you do in this state if you're licensed within this state? And so I'll pick on Alabama, for example. Alabama is like the opposite extremes. So in Alabama, once you're licensed in Alabama, you can basically practice telemedicine in any state out there. But if you are outside of Alabama, then you have to get a telemedicine license in Alabama. So the irony that we sit here as insurance guys and ponder is, well, who actually wins? So if you're licensed in Texas and Texas says it's okay to practice and treat patients outside of Texas, and you're in violation of maybe a Florida law that says you can't treat a Florida patient, but that's a Florida medicine rule, not a Texas Board of Medicine rule, but you're complying with the Texas Board of Medicine, and that's who licenses you. We really don't know what happens in that world. We've not seen any cases. I don't know if you've seen any cases, Jessica, where somebody has argued which state truly dominates the law.
Right. So I have dealt with the intersection of this and not to the point where it's gone through the litigation process, but we've just kind of had to analyze it. Most states, well, this also varies from state to state, but many states have requirements that if a physician, in order to be licensed in another state or to practice in another state, generally, so maybe not specifically with respect to telehealth, but treating any patients in another state, you need to be also in compliance with your own state laws. So even if you're not breaking the other states' telehealth requirements that apply to you, you are usually also required to be in compliance with the state laws of the state where you're licensed or located in as well. And then also, I think a lot of times it depends on where the patient is, and that might be kind of the deciding factor, especially if it's a medical malpractice situation. That's going to be the jurisdiction that applies for purposes of a lawsuit.
Yeah, and like I said, so far we've not seen any, we provide regulatory coverage and we've not seen any cases yet on the argument as to, again, if I'm complying with the Texas law and I'm not licensed in Florida, does Florida have any regulatory ability over me? And so that's a very interesting question. Like I said, I don't know if you've seen it yet, but we've not seen it.
Yeah, it is. I mean, of course, the best approach is just to hopefully try to be in compliance with all of the laws that apply to you. Okay.
Sorry for interrupting, but
that's okay.
Yeah.
Thanks for the question. I'm thinking of a similar. It can definitely result in some unusual situations. For example, it's kind of an analogous situation where we represent a pharmacy that does a lot of mail order deliveries of prescription drugs, and they're licensed in almost every state. One of their competitors was similarly, ships all over the country and was licensed in different states, but our client is based in California. Their competitor was based in another state, and the way that California's pharmacy law works, as an out-of-state pharmacy, it actually gave their competitor an advantage in not having to comply with certain laws that were applicable to that pharmacy, which was headquartered in California. So I think that's kind of goes to your point and can, result in some unusual circumstances. Okay. So that was kind of setting the background for what was going on with telehealth before COVID. Now, once it became clear that we had this ongoing emergency, which the president proclaimed as a national emergency, that authorized then the Secretary of HHS to make certain changes as to the requirements in order to ensure that sufficient healthcare services and procedures would be available to individuals with Medicare, Medicaid, and CHIP. So just some examples of those, which you all might be familiar with now that it's been going on for a while, is that there was a waiver that expanded originating site. So prior to the pandemic, telehealth services, as far as Medicare was concerned, were really limited to rural areas, and individuals weren't able to get covered care if they were at their home. That has been changed. Also, just the general expansion of the type of services that are covered, and this doesn't only apply to treatment, of course, for COVID or testing. For if people want to have their symptoms checked by a doctor, it's not just COVID. It can be any type of care can be delivered through telehealth. And then also, Medicare used to have a prior relationship requirement, so that even if these limited services were covered by telehealth, there had to be an established relationship between the provider and the patient before those telehealth coverages would kick in. That has gone away, with some exceptions that I'll touch on. And then licensure waivers, which is we were kind of talking about before, whereas in addition to the state requirements themselves, Medicare and Medicaid actually required individuals or providers to be licensed in the states where the patients are located, and that has been waived. At least under Medicare and Medicaid, you have to also consider what the different states are doing. Controlled substance prescribing has also been affected. So the DEA announced also in March, it was a little bit later, that that they, were going to allow the prescribing of controlled substances via telemedicine without a prior in-person examination. And then, of course, another important waiver is HIPAA. There's been some enforcement discretion, so HHS is not going to impose penalties for telehealth services, but they have to be provided in good faith. And this doesn't waive all of your HIPAA requirements. It's very narrow. It just has to do with telehealth services. And whereas before Medicare required video conferencing essentially in order for services to be covered, now they are allowing audio. And then the last point down here is state parity, which is kind of following what CMS did. A lot of states have enacted their own waivers allowing out-of-state providers, as long as they're in good standing, usually that's one of the requirements, to provide telehealth services to individuals located in their state. And that's without going through the typical process of getting either a telehealth license or a full medical license in that state. Okay, so specifically looking at the HIPAA enforcement discretion. So like I said, this allows audio only, so they will cover just a phone conversation, which before wouldn't have been the case. And then they also allow you to use certain public applications like Facebook Live, or sorry, not Facebook Live, don't do that. It cannot be public facing. So these are the examples of what you don't want to use. Facebook Live, Twitch, which I'm not quite sure what that is, TikTok, been hearing a lot of terrible things about lately. Those are not good platforms at all for telehealth. And if you use them, you will, that's not considered a good faith exception that would be not enforced under HIPAA. However, they did list specifically these ones after the third bullet point: Skype for Business, Zoom for Healthcare, Google Suite, GoToMeeting, and even FaceTime, I know is one of the examples that HHS has said is okay to deliver telehealth services just during the emergency period, though this is not, at least for now, going to extend beyond the pandemic. And even, a lot of these options are free. Sometimes, there are HIPAA compliant technology vendors that are not very expensive, even, less than $200 a month, I think, which is hopefully, not that much to pay to know that you're being compliant with HIPAA, even if we weren't under this emergency period. So then, along with the HIPAA waiver, you have to keep in mind that states have their own privacy and data security rules, and to the extent that they have similar or less stringent requirements than HIPAA when it comes to health information, then HIPAA is going to trump the state law. But to the extent that the state law is more broad or stricter, or involves greater amounts of information, so say things that aren't specifically health related, then that law is going to apply even if HIPAA does not. And so even with these HIPAA waivers for telehealth under federal law, you might still potentially violate a state privacy law if something is hacked, if if the appointment was recorded, or if somebody breaks in, during the appointment and records something or gets some information, you could potentially have a breach of a state law. So here is Florida's state privacy law 501.171. And this applies to entities, not just healthcare providers, but basically any entity that has personal information, which here's the definition under Florida law. So it's on 2 slides. It's a little bit hard to see, but just so you can see that it's more broad than HIPAA, there's 2 options. Either it's personal information, which is the individual's first name, first initial, and last name in combination with one of these, either social security number, driver's license, or similar numbered government document, a financial account number, credit card debit number, and it goes on here. Any information about the individual's medical history, mental or physical condition, or medical treatment or diagnosis, or their health insurance policy number. And then also it applies even if it's none of those things, if it's just the username or email address in combination with a password or security question. So that is more broad than HIPAA is. And you can see at the bottom, the potential penalties could go up to $500,000. So something that you definitely want to be aware of. And if you're practicing telemedicine, if you're seeing patients in numerous states, you want to know what those state laws are as well. All right, and here's just a little summary. So Medicare, it's paying the same rates now during COVID, like during the COVID pandemic, and not just for services related to COVID specifically. Medicaid, you know, that's partially federally funded, but it's run by the states. And so the coverage there depends on state law. And then, you know, patients can, under the federal law, receive care from providers wherever they're located, as long as they're also following state laws, and it can be used with new and established patients. I'll wait for 1 second. Oh. So down at the bottom, I just want to point out this link to the AMA website. They have really wonderful, helpful guidance on billing and coding, and also for people who have not used telehealth very much before, how to establish it in your practice, what type of policies and procedures you want to have, and training, how to train your staff on telehealth. Here is an example from the website that goes into the coding. So I mentioned earlier that typically for a lot of the telehealth services, the prior established relationship requirement is not necessary during this time, but it is for just the short check-in visits. So here under, you'll see the HCPCS code G2012, the second to last box, and that's just a brief communication, virtual check-in. So that's one that you have to have the relationship already established with the client or patient. All right, so thinking about after the pandemic period, Florida, our emergency law related to, or executive order related to telehealth, which permits certain prescribing of controlled substances during the emergency period, as well as loosens requirements for out-of-state providers to provide telehealth services to individuals in our state, was actually about to expire tomorrow. And I just saw before the webinar that the governor has extended that for 60 days. So the emergency period overall has been extended for 60 days, which then extends simultaneously that telehealth rule. But more broadly, we've seen senators calling for permanent changes to keep in place a lot of these waivers or similar, expansion of telehealth. It was being called for before, and now that we've really seen how beneficial it can be, especially when we have this highly contagious disease going around and people not wanting to or not being able to leave their homes as much. It's really, I think, brought to light and gained more support more broadly in Congress. So down at the bottom, that last bullet explains that Emily Yoder, who is an analyst at CMS, she stated, I think it was last week, that she expects CMS to make changes, and while CMS can make some changes, they can't make all of the changes that would be needed to make these telehealth requirements or waivers permanent. So some of that will take action by the legislature through congressional action, but some of it can be done by CMS unilaterally. So hopefully we will see some proposed regulatory changes this month, and that will be in the Federal Register. Usually that's in the form of a proposed rule, and then people can comment during the comment period, and then there will likely be a final rule. And hopefully we've seen legislative and regulatory changes happening much faster than usual with the pandemic. So hopefully it won't take the normal, 18-month, 12-month, 18-month period that it normally would take. And then as far as private insurance goes, they did lag behind Medicare and Medicaid at first, but I think that they did catch up, and I haven't heard from any providers that there have, I think that basically the majority or all of the private payers have expanded their policies, but you really have to check with each plan to be sure. Okay, so another consideration related to training and generally, so this goes, this is from before, this is before, during, and after the pandemic. Under Florida law, the statute that was enacted in 2019, it requires providers to be able to meet the prevailing standard of practice for whatever procedure or type of exam that you're doing. You need to meet the same standard of care as you would for an in-person visit. So if you're not able to provide the same level of care and meet that standard of practice via telehealth, then you can't provide that service via telehealth. And the same goes for documenting in the patient's medical records. You need to document it in the same way and up to the same standard as you would for an in-person visit. So some things to consider when you're in this is an analysis that you want to do even beyond just generally if you can meet the standard of care for any patient. You want to think about it for the individual patient that you're about to see, and some things to ask yourself are, what would the medical risks be for that patient based on their age and medical condition? What is this patient's individual ability to communicate about their care? And then, certain personal wearable devices might come into play to monitor, for example, I guess there's one called Dexcom for blood sugar that could transfer information directly to the physician. And then lastly, kind of something that Patrick will probably touch on is just that we don't really know right now what the standard of care is for telehealth as far as medical malpractice goes. That hasn't been decided by the courts. So that is just something to also keep in mind. And here is my email address. If you have any questions, feel free to reach out. And thank you for having me.
Hey, Jessica, hi, this is Dr. Cromer. I want to ask a few questions that have come on through our chat line, okay?
Okay.
This is from one of the listeners right now, and he's wondering if can the physician or provider insist on getting the Social Security number from the patient in an effort to get access to hospital records, because many times the hospital requires a verification of Social Security number. Is there a problem getting that through a telemedicine time period?
So no, not necessarily. If the patient is willing to give it, if they refuse to give it, I probably wouldn't push the issue. And that's kind of the situation I was talking about earlier, where, if you're providing the care in good faith via telemedicine during the COVID-19 pandemic period, HIPAA is, as long as you're doing it in good faith and you're not, using like a TikTok app or something that they say not to use, then you probably aren't going to face any backlash from the federal government if there was, for some reason, somebody interloped on the call and intercepted their information about their Social Security number. But there could still be a state law claim. So that's why it's always best to, if you can, have a HIPAA compliant platform that will keep you, better protected.
Yeah, and I'd like to jump in on this one as well. So, Jessica did a really good job of pointing out the data breach laws, and the data breach laws are very specific to each state. Obviously, there's federal law too. Most insurance policies have a little bit of coverage built into it. for a data breach, cybersecurity type coverage. It's usually a very low limit that's involved in it. But truly, you have to have expertise. You could have a patient who resided in Illinois and you treated them in Florida, and you're going to fall into Illinois law. So you may have a data breach and you may have to comply with 40 different state laws because you treated patients in 40 different states. And so the data breach aspect of that says, now, would I want to store a social security number? Because once I've stored a social security number in my system, if that gets hacked, then that, that's at the highest level of protection. So, you have to think about that when you decide to get that social. Maybe you get it just to get the access to the records, but you may want to make sure that you don't store that anywhere so that it can't be breached.
Good point.
Another question came in as far as billing. Jessica, do you know, are you informed on going back to that slide that talked about billing codes? Sometimes the technical component, especially with elderly patients, can get in the way of having a completely successful telemedicine visit. They can be registered, they can be all set up, we can walk through it, but sometimes what happens is that when it comes down to it, either they don't press the right button and we don't get the video component going, but we can carry on with a audio component, either through the computer or through the phone call. Does the coding need to be changed when that happens?
For as far as Medicare, my understanding is because of the waiver allowing for audio only, right now, that would not need to be changed. But for private insurance, I'm not sure if there would be, a different requirement. I'm kind of flipping through something that I have here that summarizes some of the billing elements. And yeah, I don't remember seeing anything because of that waiver allowing for the audio only. I don't think it's an issue as far
as of now, during this pandemic time, during the waiver time period, you can still bill for telehealth if that was your intention. Yeah, even though it was just audio. Okay.
But if these waivers, went away, if the pandemic suddenly ended tomorrow, then yes, it's probably not. Then it will be different.
Yes. I do want to tell our viewers that this time of input that you spoke of is going on right now. They're accepting input from physicians and other providers around the country concerning telehealth. One thing that was wavered, and an exception that I can't see staying around forever, is the waiving of co-payments, correct?
Oh yes, I don't think that will be permanent.
That typically is looked upon as sort of a form of insurance fraud. But that has been waived during this time. It can be something that anybody who is interested can give their input through the platform provided there on the slide. Jessica, are your slides copyrighted, or is there a way that we could get a copy of these for our members later on?
I could send them to you. Yeah, I'll just email them to you.
Okay. I may get some more questions along the way, but thank you for your information tonight. And Patrick, let's turn it over to you to hear things from an insurance viewpoint that we need to know.
Very good. Thank you, sir. And thank you, Jessica. You did a very good job laying the legal groundwork for us. Let's start with real basic stuff. We'll just talk a little bit about claims made and occurrence coverage and tails and that kind of stuff. So, when you have a policy in force, that policy responds either based on the date of the occurrence or the date the claim is made. For the most part, probably 80% of the coverage that's out there is what we call claims made coverage. So for the most part, you're really going to be focused on when the claim is reported. So from looking from that perspective, physicians in the old days, they used to have their individual policies, and those policies covered them 24/7 for anything they did. In today's world, you have a lot of hospital coverage. You have a lot of large group practices that are buying coverage for their providers. And in those situations, often the coverage is scope of duty narrowed down to the person who's actually buying the coverage, the group itself, the hospital itself. So a lot of physicians, they get their practice acquired by a hospital, and the hospital is now providing them their malpractice coverage, and they think everything is great, but they don't really understand that the world has changed, because now that the hospital is providing their coverage, the hospital controls the coverage, they don't. So we have seen instances where physicians have gotten into telemedicine thinking that their hospital coverage or their group coverage would extend out to their telemedicine practices that they were doing on their own. And they learned that lesson the hard way, unfortunately, that when the claim comes in and it's not related to the services that they provided on behalf of the hospital or their group, then you're in a coverage denial situation, and obviously that's not a good situation to be in. So we caution everybody to make sure that they understand their own coverage before they get into this, that they understand whether their coverage is their coverage or whether it's the hospital's coverage or the group's coverage, and they ask those questions and they get those answers and make sure that they truly are covered if they're going to expand into this activity. As we talked the other day, Dr. Cromer, that obviously if it's the group that's doing it, then everything is probably okay. You hope that the group is making the right decisions and that there's no exclusion in the policy. Mostly what we're going to look at for the true pitfalls in these situations are the licensure laws. So, pretty much every malpractice policy or professional liability policy out there is going to have an exclusion or a restriction in an insuring agreement that says you had to be duly licensed in providing the services that your license allowed you to provide at the time you provided them. So from that perspective, we've been writing actually, telemedicine and virtual medicine. We actually created virtual medicine policy, I think back in 2014. So we've been kind of at the front end of this for a very long period of time. And so there are certain coverages that fit better for this exposure than a true med mal policy will fit. And I talk mostly in that setting because when you're a software platform that physicians are using, you're going to need a coverage that applies really more so for the breaches, for the data, and all that. But you also may very well get named in a malpractice lawsuit. So there's this like hybrid area of where you really don't have any professional liability exposure because you're not a healthcare provider, but you're facilitating the practice of medicine. And so we have seen those cases. Mostly what you get is a defense out and say, look, they didn't practice medicine, they were only the platform, but you still have to pay an attorney to go off and put that answer in. So you start to see now really the big breach carriers like the Beasleys and the NASs out there. We're a malpractice carrier, so we don't really, while we provide very minimal legal defense and cyber policies attached to our policy, that's not our expertise. You need to have that expertise. That's a very distinct world to be in. So, we've seen Beasley's and other companies kind of, because they were the cyber carriers, it made more sense for them to be the carrier because the med mal was insignificant to the cyber exposure for that. So for your physicians, what they need to think about, well, if I'm just going to be doing telemedicine, what does that mean? If I'm treating my patients that I've already seen through telemedicine, then that's really what we would call telemedicine. What we would call virtual medicine is now I'm going to treat somebody I've never seen before and I'm never going to see. And so we use that internal distinction of telemedicine and virtual medicine. In the telemedicine, where you see it, where I think it has always made sense and where we saw the most growth over the last few years before COVID, and I will say COVID truly has changed the world. It's changed it very quickly. I hate to say, unfortunately, I think it was a necessary thing because I think this is what we needed to jumpstart telemedicine. My father was a physician and I used to go with him to the hospital, and I can remember him standing there one day and out in the waiting room of the hospital with all the people sitting there and him just laughing to himself. And I said, what's so funny? He goes, we bring a bunch of sick people together and we put them in a room and have them sit there for a while. And somehow we think that's a good idea. So I think when you look at really chronic illness and infectious diseases, it doesn't make a lot of sense to have people in a waiting room, especially if you're going to combine those two patient populations. If that's not going to be a good thing. So I think ultimately this had to happen, and I think it's a good thing. Likewise, it is a very complex, and it's morphine, and it's in its infancy. So I think, as Jessica said, none of us really know what we're talking about at this point. We've been doing this an awful long time, and I still, honestly, every day I wake up, I wonder, what's going to be different today between all the licensure laws and everything like that. So if you look at kind of what I think is probably the biggest problem within Florida would be their physicians. Because you have a good population of physicians who don't carry malpractice coverage. So now think of it from this perspective, and I'm a doom and gloom kind of guy, so this is just my fun fight. But you have a patient who's been treated by a physician that's fair, and that patient finds out that they have a problem that kind of has been misdiagnosed a little bit. They don't really know what's wrong with them. So now they go into a telemedicine situation, and you're the lucky physician that gets that patient contacted. So you start dealing with that patient, and you go down maybe the same road that the other physician went down. And eventually you find out the patient has something, you diagnose it properly, but it takes you a little bit of time because after all, you're not seeing the patient as in the office, you're treating them through a telemedicine situation. And eventually you get the diagnosis right. And ultimately, a lawsuit ensues in the future over that, and the physician that really was the problematic physician is there, then more than likely, unfortunately, in the state of Florida, your plaintiff attorney is going to go after you because you have insurance. And that's an unfortunate side of the bear position in Florida, but I think it's really, in the telemedicine world, what we're struggling with right now, and I'd ask Jessica at some point to jump in on this because she did a good job on the standard of care. Really, what is the standard of care? I mean, obviously, if you're in the emergency department, you have a standard of care. If you're in the physician office, you have a different standard of care. Nobody really has truly litigated out the standard of care in the telemedicine world. There are actually some jury surveys that indicate really fascinating that older patients look at telemedicine and say, well, the person was stupid from going and using that, so you can't hold that physician to the same standard that you would a physician that saw you in person. And you were stupid for going and being treated that way. I'm 65, I would never let somebody treat me via a cell phone. So that's just your fault. And at the same point, you can get into the millennial generation, and the millennial generation looks at it ironically, much to the fact that, hey, this is a convenience to me. It made my life easier. So no, I'm not going to hold you to the same standard as if I came and sat in a waiting room and waited. So it's really kind of fascinating that I think society would accept a lower standard of care for telemedicine. And I'm almost concerned that it seems like medical societies and the medical community itself is pushing for this parity. And I understand you want to get parity of pay, and you want to get, that, but in doing that, are you also now creating a situation where you could have actually had somewhat of a lower standard of care that would have been beneficial? And we shouldn't let that slip through our fingers, right? Because I think society would accept that as well. Jessica, what are your thoughts on that?
I think right now, especially if there are, certain diagnoses or visits that are going to require you putting your hands on the patient to really be sure of your diagnosis, that's the kind of thing that I think you need to avoid. Whereas and especially if you're doing audio only, that's another place to be careful, versus actually like being able to see the patient. And that's kind of why the video is really the gold standard and the best option. So I think, doing video when you can and limiting it to things that you can diagnose and confidently feel like you can meet the standard of care via video and or audio, and not taking any chances where there's something that you really need to either see in person for whatever reason, to use, a certain tool to get a closer look, or if you need to put your hands on the patient. Those are the things that I think should be avoided for now.
Yes, so, to jump on to the licensure and COVID-19 licensure and kind of some of what we see coming down the road as problems, and again, this will kind of dovetail with the doctor-patient relationship pitfalls as well. So, if I've got a temporary order in Illinois that allows me to practice telemedicine in Illinois without a license, and that order gets extended, and then that order finally expires at a certain point in the future. And I'm not licensed in Illinois, but I've established relationships with patients in Illinois through my telemedicine adventure. Now I am not licensed to practice anymore. Have I abandoned my patients? And so we highly encourage everybody to get licensed in every state that they're going to see a patient in. No harm will come out of that. Certainly it's expensive, it's cumbersome. I think we end up with a national licensure at some point out of this. I think that's the only solution to it. I know the states are going to fight like heck against that, but I don't think really, we can move forward truly in this world without some form of national licensure. And as of right now, we don't really know how you end a patient relationship via electronic telemedicine. I don't think they've ever established any law on what the proper, and whether or not the relationship is ever over. So, if I treat Mrs. Jones and 7 months later she contacts me via my porthole and I treat her again, and then 3 years later she's diagnosed with breast cancer, was she still under my care? That's one of the big questions too, is to when does that relationship end? And certainly I think if you had a formal end to the relationship, where you sent them an email and made them sign something saying that you're discharging them as a patient and they're accepting that discharge, that would go a long way. But I don't know of anybody that's doing that at this point. So that, as an insurance company, that starts to concern us as to what kind of liabilities are we going to run into 4 or 5 years down the road when some of these things start playing out, that you treated me during my COVID lockdown, but now 4 years later I have something that you might have caught, and so you might have missed it. I don't even know, but I'm going to go ahead and sue you too. Then you throw in, and I'll say, joint defense is important. The worst cases that we see as an insurance carrier are the cases where you have multiple defendants insured by multiple different insurance carriers, and everybody's pointing the finger at each other. And those cases are just, for a plaintiff attorney, that's the lottery. They love it when insurance companies fight over responsibility in front of a jury. So, again, if you're practicing with people in a telemedicine situation, you want to probably make sure that you're all insured by the same carrier. That would be beneficial. A lot of people have talked about the immunity with COVID, and truly, if you look at almost all the immunity laws that I've seen, I've not seen one that did not have an exemption in it for gross negligence. And so they truly are not immunity in the sense that you are not immune. You still have to answer, and somebody has to plead the immunity. And as soon as you throw the gross negligence standard in there, there's going to be an argument that what you did was willful, wanton, and gross. So you're still going to require a defense. Now, the defense should be pretty easy, I would think. And again, I look back at my whole history, and I think, if there isn't immunity in a true pandemic situation, then, as a society, I don't even know how we respond to the next pandemic. I mean, if truly our first responders and our physicians are being sued for going in and practicing for 15, 20 hours in a pandemic situation, and society lets that move forward, then I think, we've all got a bigger problem. But, those are really the things that we worry about the most, are how truly are the juries going to look. Now, the good side is we also look at, conversely, that, during the pandemic, the healthcare system probably needed this as well, because again, I think people are looking at the healthcare system more as a heroic system. I think what we were seeing as far as trends go in our world, trends were not pretty. Claims were going up, not so much from a frequency standpoint, but from a severity standpoint, dramatically. And what we call frequency of severity is up dramatically, and nobody can argue with that. We think the plaintiff attorneys have gotten better, much better at selecting cases. We think they figured out, they kind of went with the reptilian theory for a little while, and that worked, but it got verdicts that were so big that they were overturned by Supreme Courts and thrown out. So they've kind of toned that down enough now where they're banging pretty high verdicts and they're sticking. And in fact, I think there's been more verdicts over $2 million in the last year than there's probably been in the last 5 years combined. So we see a real deterioration in the value of cases up until COVID hit. But now with the COVID shutdown and the courts shut down, we're starting to see a little bit of a reverse trend where, the settlements are more reasonable. So that may have a positive effect on results as well. It will probably take us a good 5 years to figure that all out. But it's going to be very interesting to watch this. The key is going to be, I think, what happens when we open back up. For example, there's big talk here in Alabama about, we've got 1,000 new cases today, and and people are worried about it. But you look at it, and the people that we're seeing the growth in cases, but the growth in cases is younger populations that are not even really that sick. They throw in the stat that that UAB is at 80% occupancy. That's true, but only 20% of that occupancy is COVID related. So a lot of the hospitals around here, once we open the state back up, they were prepped to run it at about 120%. And we were joking, on the way home today, I was joking with one of my other insurance guys because he said, well, it's impossible to run at 120%. And I'm like, well, it's not really, because you're running at 100%, maybe from 7 o'clock to 7 o'clock. So if you run from 7 o'clock until midnight and you just shipped out your nurses, you could truly run at 120%. And he was like, wow, I never really thought of it that way. But they had already cut deals with a lot of the nursing organizations in town, because the idea was, with all the money that was lost, he was shut down, to recapture that money. And patients need elective surgeries. So, we're seeing a lot of the spike up in the cases that are not, they're not necessarily that sick, but yet that seems to be what everybody talks about. And then what do? Do you shut the system down again? Because if you shut the system down again, there's going to be people that are going to have heart attacks and all of that are going to go untreated, but for telemedicine. So we get right back into, well, what's the standard of care? Well, the standard of care is if I can't go to the hospital and I've got no chance of being treated, then I think any treatment I get is probably better than nothing, right?
Yeah. Mm-hmm. Patrick and Jessica, some questions have come in. Thank you, Patrick, for those thoughts. Some things I got from that is just make sure our policy, whether it's an individual policy or a group policy, includes some language about telehealth. Make sure we stay in our scope of our duty. The topic of national licensing certainly is going to be something in the future that we're going to be hearing more about. And none of us are fully immune from any malpractice, even though the platform is maybe in a less intense, less personal, less one-on-one setting. We still have obligations that we all have to perform by. Did any of you have any knowledge on, say, the numbers of telehealth visits, say year to date last year versus the numbers of telehealth visits this year? And then after COVID dies down, is there an anticipation that telehealth will die down a little bit, or what's your knowledge on that?
Yeah, I wish I did have those numbers. I should have those numbers for you, but unfortunately I don't. We've not really had the time to really get into really good numbers. I mean, for the most part, we insure a lot of really large national providers, and especially in the ER setting. Surprisingly, what we saw is even in the ER setting, a lot of that moved into telehealth. So it's not like I get to see all these telehealth visits. What I used to see as ER visits, now I'm seeing as telehealth visits. So visits in the aggregate aren't up necessarily. In fact, they're probably down by about 10%. But that spread of visits, there's a really good slide, and I'm trying to remember who put it out just about a week or 2 weeks ago. I'll try to track it down and send it to you, sir. But there's a really good slide that kind of gets into that. Yeah, it was Dr. Van Horn from Vanderbilt. Had done a really good presentation for the malpractice, the medical professional liability MPL symposium. I will find the link to it because he's got some really great slides to show how much the telehealth really boomed up during COVID, but also how it was already starting to crank up before it. But once COVID took over, it really, lit the fuse basically. So it's a dramatic shift. I would say that you're probably looking at somewhere roughly between from being 10% of visits to probably being closer to 40 to 50% of visits during COVID.
Yes, I had heard somewhere around 4 to 5 times the number of visits during the COVID situation. Any knowledge on, since the Florida legislature passed their statute last year, how many out-of-state providers have registered to be telehealth providers in this state?
I don't know that. I was fascinated because what I read today basically said that the law that was signed didn't include the requirement to register, but the law that I think the law that was proposed had the registry in it, but the law that was signed by the governor doesn't have the registry in it, so they're not required to pay that right now, I think, technically.
So the actual statute allows out-of-state providers to register in order to provide telehealth services here. I think maybe you're thinking of the executive order that doesn't require them to be.
But yeah, I think the law that I guess the Board of Medicine put together was kind of mirrored by the governor and what he signed, from what I understand. But what he signed could not have any kind of financial. So I guess the revenue, it could not be a revenue law. So I was hoping somebody could clarify it for me because I didn't really understand it. It just sounded kind of weird.
Let me get back to, are you thinking of the actual, like the
I think
statute?
technically right now you don't have to pay and you can treat patients in Florida.
Yeah, I think that's just for the emergency period, but
Yeah, I think you're right. I think it is for the emergency period.
yeah,
Okay.
the statute, once we're out of the pandemic, then they.
So in-state providers, we never did have to pay or register to do telehealth in Florida. Out of state, the statute required it, but that has been waived during this pandemic out of state. I wonder how we could get any knowledge on how much that is happening. How about those of our members who want to provide telehealth in other states? Jessica, was that on your first slide about how many other states allow out-of-state providers to provide telemedicine?
I think right now,
I
think right now it's most of the, at least during the pandemic, I think it's pretty widespread. It might be like every state at this point. Yeah, I think I had on my first slide like 46. That was before, and it could be in different capacities or with different requirements. And something kind of interesting that popped into my head when Patrick was speaking earlier is definitely preferable to have the out-of-state license or the out-of-state telehealth certification or whatever the state requires. But if you are becoming licensed in a bunch of different states, you also have to be able to keep up with that licensure. So if your address changes, you're required to usually report that within 30 days, and so you're going to be that's one example. Also, if you have a medical malpractice lawsuit filed against you or a settlement entered, every state has different requirements for reporting that. And if you get sideways with one state and your reporting requirements, that can have effects on your home state and your license in all the various states.
Yeah, that's a good point too. I didn't even really think about limits and with a Florida physician carrying a 250 limit and you're starting to treat patients in other states, that limit is certainly not adequate. And in fact, there are a handful of states like New Jersey and Pennsylvania that require specific limits that are higher than that. Virginia, everyone thinks Virginia requires the statutory limit, but it really doesn't. It's the hospitals that do. And being telemedicine, you probably wouldn't be subjected to the hospital requirement, but you're also going to be sitting there with juries that are going to expect that you're carrying $2.2 million of coverage. And when they find out you only have 250 grand, they're going to get mad, and it's not going to be good.
There's also, sorry, my train of thought just completely left my brain. I'll think of it in a second.
Just a minute, I would like to remind those of you on the webinar about HCMA's Physicians Wellness Program. This program, as you know, provides a safe harbor for our members to address life difficulties in a confidential and professional environment, especially during this time of uncertainty, challenges, and some additional stress that this ongoing threat brings upon us. And the program is fully funded and available to all HCMA members. If you'd like to find out more about the Physician Wellness Program, you can go to the HCMA webpage, and that's hcma.net, and look at the list of providers and additional wellness resources.
Okay, that came back to me.
Yeah, I knew that would. Okay, go ahead.
So prescribing and dispensing drugs is another issue that can come up. HCG is one example. In Florida, a dispensing practitioner could dispense that to their patients, but if you're treating patients in different states, they might have different requirements or rules regarding, you know, controlled substances and whether they can be mailed to a patient or not. And so that's just another thing to keep in mind when you're treating patients in different states.
Mm-hmm. All right, Patrick O'Doherty from ProAssurance and Jessica West from Shumaker Loop here in Tampa. Thank you for your time. Thank you for joining us, our members, and we hope this information was valuable to you. Have a good evening.
Thank you all.
Thank you.